Alors, bonjour et bienvenue à la 20e.
Order. Good morning and welcome to the 20th meeting of the Standing Committee on Indigenous and Northern Affairs.
On the unceded territory of the Algonquin Anishinaabe Nation. Just a reminder before we get going about those witnesses, those 12 witnesses that we had to supply for the fourth study by noon today, as well as the requirement for the rest of them by noon on the 20th of May, so that the analysts can get on with inviting these witnesses.
Today we continue our third study on the administration and accessibility of the non-insured health benefits NIHB program for Indigenous people.
Panel in a moment, but first a few reminders. Je voudrais vous rappeler.
I would like to remind you of the Board of Internal Economy's requirements regarding physical distancing and wearing masks indoors.
To ensure an orderly meeting, I would like to outline a few small rules. Members or witnesses may speak in the official language of their choice. Interpretation services in English, French, and Inuktitut are available for the first part of today's meeting. Please be patient with the interpretation. Sometimes it has to go from Inuktitut to English, then to French, or vice versa. So there will be a little delay. The interpretation button is found at the bottom of your screen in either English or French or Inuktitut. If interpretation is lost, please let me know. We'll stop proceedings and try to rectify the problem before continuing. Before speaking, please wait until I recognize you by name. If you use the raise hand feature, you can get my attention that way if you need to. And if you are on the video conference, please click on the microphone icon to unmute yourself. Those in the room, as you know, your microphone will be controlled as normal by the Proceedings and Verification Officer. When speaking, please speak slowly and clearly. When you are not speaking, your mic should be on mute. And a reminder that all comments should be addressed through the chair. And also try to stick to the time that is allotted to you. We start off with the witnesses, each making a 5-minute statement. Two of the three witnesses are here, so we'll get on with it. I'd like to welcome Dr. Lynn Tompkins and Dr. Philip Poon from the Canadian Dental Association. As well, Carolyn Lidstone-Jones, Executive Director, Indigenous Primary Healthcare Council, who will join us hopefully shortly. And finally, Maggie Putulik, Vice President, Health Services of the Nunasi Corporation, who is in person today. So without further ado, I will invite Dr. Lynn Tompkins to start off our proceedings today. Dr. Tompkins, you have 5 minutes.
Thank you, Mr. Chair. Bon après-midi à tous les...
Good afternoon to all the committee members.
Speaking to you from Toronto on the traditional territory of the Huron-Wendat, the Haudenosaunee, and the Anishinaabeg nations, and the Mississaugas of the Credit First Nation. And I'm pleased to be joined by Dr. Philip Poon, who leads our subcommittee on the Non-Insured Health Benefits Program and has extensive experience on this subject. He joins us today from Winnipeg, located on Treaty 1 territory and the homeland of the Métis people. At the Canadian Dental Association, we know that oral health is an essential component of overall health, and we believe that all Canadians have a right to good oral health. That is why we are fully supportive of efforts by all levels of government to improve Canadians' oral health and to increase their access to dental care, especially for Canadians who need it most. CDA has long advocated for investments in Indigenous oral health and access to dental care. We have been collaborating for over a decade with officials who manage the dental component of the NIHB program and provide technical advice on its administration. And so today, we would like to offer 3 recommendations in the context of your current study. First, we are calling for better access to facilities where dental treatment can be performed under general anesthesia. Many high needs patients, and particularly children, require dental procedures performed under sedation, specifically under general anesthetic, and this requires a surgical facility. This is often the case for Indigenous children who live in remote communities without access to regular dental care. And these children often have severely decayed teeth, which can be difficult to treat in a conventional dental office setting. And although the treatment is covered by the NIHB program, it is often a challenge to access the surgical facilities in which to provide the treatment. And in many cases, hospital operating rooms are used. Even prior to the pandemic, it could be challenging to find the necessary OR space or staff. Treatment was often delayed for months, and this has all been worsened by the toll COVID-19 has taken on the healthcare system. The resulting surgical backlog means that this issue will likely persist for some time. One option is to make better use of private surgical facilities, which exist in many large cities. However, these clinics often charge rates significantly higher than the NIHB program's reimbursement levels, or they impose fees which are outside standardized system of dental treatment codes, which are not reimbursed at all. Another option could be to construct dedicated, Indigenous-run surgical facilities in communities that serve a high number of patients that qualify for the NIHB program. Second, although the NIHB program compares favorably to other publicly funded provincial or territorial dental programs, some patients continue to face significant barriers in accessing care due to the program's burdensome administration. Many common treatments, such as partial dentures, require pre-authorization, despite the exceptionally low rejection rates. The pre-authorization process for other treatments, such as crowns, can also be more complex under the NIHB program compared to other dental programs, including the federal government's Public Service Dental Care Plan. And furthermore, other common services, such as night guards for bruxism or tooth grinding, are included as a service under most dental plans, such as the PSDCP, but not covered by NIHB program. The program has already made significant improvements in the past, such as removing the pre-authorization requirement for root canal treatment. It's much appreciated. Given that Indigenous oral health outcomes have lagged behind those of the non-Indigenous population, the NIHB program should aim to facilitate efficient, quick access to care, rather than focusing on cost containment. We recommend that the program conduct a comprehensive review of the administration of dental coverage to ensure that any pre-authorization requirements are in line with best practices of other dental programs, both public and private. And finally, CDA applauds the historic investment in Budget 2022. However, at a time when the federal government has committed to investing over $5 billion in dental care for Canadians, Indigenous oral health must not be overlooked. As it currently stands, none of this funding targets the nearly 1 million First Nations and Inuit in Canada eligible for the NIHB program. And this may actually increase the significant oral health inequities between this group and the broader Canadian population. The federal government should, in partnership with Indigenous governments and other relevant stakeholders, develop an oral health investment strategy to improve the oral health of Indigenous communities. And beyond the concerns outlined earlier, this could also include things like investments in education and awareness campaigns, public health programs providing preventative care, as well as access to clean drinking water and community water fluoridation. Thank you for this opportunity to participate in a study of this important federal initiative, and Dr. Poon and I would be happy to answer any questions that you might have. Thank you.
Thank you, Dr. Tompkins. Glad you could join us today. Next will be Carolyn Lidstone-Jones, CEO, Indigenous Primary Healthcare Council, who has now joined us. Ms. Lidstone-Jones, you have 5 minutes.
Ani, everyone. As a representative from the Indigenous Primary Healthcare Council, which supports Indigenous primary healthcare organizations across the province of Ontario, we would like to thank the House of Commons Standing Committee on Indigenous and Northern Affairs for the opportunity to appear as part of a panel witness in view of its study, Administration and Accessibility of Indigenous Peoples to the NIHB program. In providing feedback to the study, to the non-insured health benefits program, we're doing so through the lens of an end user perspective for First Nations, Métis, and Inuit, inclusive and solicitous of the northern, rural, and urban Indigenous communities that we service here in Ontario. The 4 themes and observations that we would like to report on are contained under affordability, accessibility, exclusionary, and safety. With regards to affordability, significant challenges noted for the northern, rural, and urban Indigenous populations include the following. Many service providers, whether it be dental, optometry, pharmaceutical, or others, require Indigenous clients to pay for their services upfront and then independently submit receipts to NIHB for reimbursement. For some, this creates affordability challenges as the services can be quite extensive and expensive. When looking at eyewear expenses, costs can be hundreds of dollars. Costs for emergency dental care alone can be upwards of thousands of dollars. For example, root canal therapy alone averages between $520 to $1,200 per tooth. Plus, there is a general lack of awareness among service providers regarding the NIHB program, especially in urban settings. Many service providers are unaware of the program and their ability to access or register. As such, in many cases, Indigenous clients are not offered the option of provider-submitted reimbursement. As such, in many cases, Indigenous clients are not offered the option of actually having the provider submit reimbursement on their behalf. If the client requests direct billing to NIHB, it is often denied by the service provider. On the other hand, many service providers that are aware of the NIHB program choose not to participate because of the predetermination processes and the length of time to process. In addition, it is reported by providers that the wait times to receive payment back from NIHB is extensive. So some providers are opting not to register as a provider or to remove themselves as a provider on the pre-approved registry list. Finally, out-of-pocket costs for travel remain a significant challenge for Indigenous peoples in northern, rural, and urban settings. For those living in northern and remote regions, there are out-of-pocket costs for travel that continue to escalate with increasing gas prices, for example. For instance, the fees for driving are currently established at 22 cents per kilometer. This fee is not keeping up with the cost of inflation, and it further impedes the affordability of individuals to access appropriate health care. Comparatively, reasonable allowance rates that were identified on the Government of Canada website for 2022 were as follows: 61 cents per kilometer for the first 5,000 kilometers driven, 55 cents per kilometer driven after that. And in Northwest Territory, Yukon, Nunavut, there was an additional 4 cents per kilometer. In addition, meals are reimbursed at a maximum of $60 a day, comparatively to the Government of Canada website at $69 per day without receipts. For the urban Indigenous population, all travel is out of pocket as access to designated NIHB medical transportation is minimal due to the expansiveness of service provision. Individuals traveling to urban settings for services are required to pay up front for taxi and parking. Both costs are extensive, especially in metropolitan areas where a lot of the specialty services are housed. Parking alone can range upwards of $30+ a day in the downtown core. All in all, upfront and out-of-pocket costs for travel and services create significant affordability for those who may not have the affordability to do so upfront. And as a result, this may force them to abandon their much-needed care completely. And when they eventually enter the system, we are now seeing them in emergency settings rather than curative or in preventative type settings. Some additional things that we see with regards to challenges. There is limited access to service delivered by Indigenous practitioners. While there is an NIHB service provider list for mental health, it is mostly comprised of non-Indigenous practitioners delivering mainstream services. Developing a similar list and funding Indigenous practitioners with an emphasis on traditional healing and wellness supports is essential to dealing, especially when we accept culture is treatment and culture is healing. Reclaiming with culture, land-based healing, and connecting with cultural service providers are well-known strategies that successfully support the Indigenous population on their healing journeys. Travel also poses additional challenges from an accessibility lens. Often the approval process for medical transportation is delayed or not expedited in a timely manner, especially if specialty services are accessed in last minute. This results in clients having to cancel their appointments, and we know that the wait times for most specialists and diagnostic testing is quite extensive. So this then poses further delays to their treatment and care. Connecting with NIHB representatives in real time when experiencing an issue or having questions is a significant challenge. This is a well-known reason why service providers choose not to work with NIHB. It is a contributing factor to many Indigenous people not receiving the care that they need. In many cases, out of frustration, they will abandon the process and not attain supports through the NIHB program because of it being time-consuming, complex, and labor-intensive to navigate.
So, Ms. Lidstone-Jones, you're at 6.5 minutes already. So if you could wrap up, please.
Yep. Yeah. Racism, I think that the final ones that I'll do is focus on our racism in the healthcare system. Racism in the healthcare system is deeply rooted since the time of Indian hospitals, when they were created in the 1930s. Indigenous people experience inequitable access to healthcare services and receive subpar care, and this often results in death. When we speak about the anti-Indigenous acts of racism, reflect on the treatment of Joyce Escuwan, Brian Sinclair, and others. But we also reflect on those who did not access much needed services because it was too late, or because of their anticipation of how they would be treated. There is a significant gap in cultural safety and culturally safe care. We recommend that mandatory training be imposed to all NIHB services and service providers to ensure that safety is an ultimate lens. We also
Thank you. I'm going to have to stop you there. Miss Maggie Putulik, you have the microphone now for 5 minutes.
Thank you. My name is Maggie Putulik. I'm here today as the Vice President for Health Services for Nunasi Corporation. I would like to start off by saying that it is an honor for me to talk to you about the importance of the non-insured health benefits program for Nunavummiut Inuit. At the end of my presentation, I'm going to outline 3 key recommendations to improve the policy. Nunasi Corporation, who I work for, is a Nunavut Inuit Birthright Corporation owned by 2 regional Inuit associations, Qikiqtani Inuit Association and the Kivadlik Inuit Association, and 1 regional development corporation called Kivadlik Corporation. We're the oldest Inuit development corporation in the country, and we were created in 1976 by the, should I remove it? Okay. By the Inuit Tapirisat of Canada at the time, now known as Inuit Tapirit Kanatami. And Nunasi Corporation was created to be used as a vehicle to ensure Inuit participation in economic development. Nunasi has investments in the medical accommodations known as the Largas, and we are situated in Ottawa, Winnipeg, Edmonton, and Yellowknife. As there are no specialized medical services in the north, Inuit must be sent to the south to receive specialized medical services. The Largas are known as home away from home, with culturally appropriate programs offered to medical patients and their escorts. We provide accommodations, lodging, and transportation covered by the non-insured health benefits program. Nunasi, we also own Polar Vision, which is located in Yellowknife, but does services for optical care in the Nunavut communities. The non-insured health benefits program is a significant program for Inuit. And although there are many benefits to the program, today I'm going to offer 3 specific areas of improvement that would greatly improve the outcomes. First, first of all, the federal government should enter into a long-term 10 to 15 years agreement with the territorial government of Nunavut to ensure that appropriate investments can happen. Long-term agreements provide greater certainty in securing the essential services we at the Largus provide to Nunavut. Second, the Government of Canada should develop and implement a territorial user transportation policy. And when I use the term user, in the medical world, a user is a patient or an escort. That's the term that is used in the medical world. So it should develop a territorial user transportation policy both for Nunavut and the Government of Northwest Territories to avoid misinterpretation of the policy pertaining to medical escort eligibility. Escorts provide a critical function in the Inuit health services. They accompany the patients. They assist patients with mobility issues and language barriers, and also social and psychosocial support and emotional support. We have experienced many inconsistencies in applying the escort policy, in particular with the GNWT. So we need to implement, or the federal government needs to implement, a clear policy that specifically outlines who can be eligible to have an escort, because the policy as it is at the moment is vague and broad, and it could be misinterpreted by, in particular, medical travel personnel within those two levels of government. NUNAS's third and final recommendation is to update the non-insured health benefits program policies related to vision care in Nunavut. Currently, the NIHB pays $300 to $400 with one pair of glasses every 2 years for adults and every year for children. These program benefits are below what is considered standard in vision care programs elsewhere in Canada. We have been given the most basic amount to cover our glasses. We recommend that NIHB pay market rates or close to it for eye exams and glasses so that Nunavut can afford to utilize this program. As well, contact lenses should be included, and laser eye corrective procedures should be eligible in appropriate cases. Finally, service days from opticians in the Nunavut communities are very limited. We frequently hear that the low number of available service days prevent Nunavut from accessing vision care, and that is unacceptable. As a professional who's worked in the health services in the health network for the past 15 years, and someone who's been working diligently with the Largus, Polar Vision, and other healthcare providers that utilize the NIHB program, I have outlined for you today these 3 key policy recommendations. I believe that we could work collectively to make the program even better. I look forward to your questions. Puis je vous remercie pour cette opportunité.
And I thank you for giving me the opportunity to appear today. Thank you.
Thank you, Ms. Patulik. We'll now proceed with the questions. We'll start with Mr. Schmale. Mr. Schmale, you have 6 minutes.
Thank you, Chair, and thank you to the witnesses for the great testimony today. In previous committee meetings, we've heard about the crippling level of bureaucracy that is associated with this program. And I think, Ms. Lidstone-Jones, you were just kind of getting into that. You're nodding, okay? Yeah, you were just kind of getting into a roll on that. Your time ran out. Would you like to complete your thought?
Much appreciated. We can speak from our Ontario perspective here for the communities that we service here. What we're hearing is a lot of the resistance we have from current providers who are already registered or who may express being interested, that the actual bureaucracy and the amount and labor intensivity tied to having to go through that process is something that they just don't have the time to do, especially in light right now where we're in massive HR crises, where recruitment and retention and the increased wait times become an additional burden on their time, appropriate supports to be able to do that. So it isn't necessarily that they outrightly are just not interested in serving. They're opting because of the bureaucracy tied to participate in the program becomes their choice to say, you know what, for the amount of time and the length of time it takes us to register, and then it takes us to go through all of the pre-approval, and then the length of time for us to receive payment, we just are not able to keep up with that administrative burden to do that. So that has been something we are seeing where more and more people are walking away from services because they can't afford to pay it up front themselves and then seek reimbursement from NIHB.
Right. Okay. So those people sadly just don't get the service they need. Okay. Yeah, you're nodding.
Yeah, and that's why we mentioned many of them end up, instead of preventative stages, now going, if you're looking upstream versus downstream, now entering into a merge where it's then more costly to the system to service later on.
Yeah, absolutely. Just out of curiosity, are your members communicating with the department through fax? Some. It just depends on the location. We still have severe challenges. One of the recommendations we had also ties to we still have a major digital divide, especially for many of our remote First Nations communities. So that becomes an ongoing challenge with the stability of internet and lack of broadband, those kinds of things. So that adds also further complexity to navigating the system. So we have a combo of both. In a previous meeting, we had testimony from a pharmacist who talked about having to use fax because I guess email hasn't got to that department yet. He also mentioned that sometimes when you fax, the paperwork gets lost. Physicians, physicians have to start the process over again, and this also compounds to the already frustrating system that exists.
And wait times, yes. Yeah, and if paperwork gets lost, the pre-approval process then is impacted. And then, then if you secure an appointment time and that paperwork is not done in time, that delays then your travel to be able to have, whether it be flight, whatever it is that you're doing, booking accommodations. So it just trickles down to everything and delays everything. And we have had people miss their actual appointments because of the system failing in that regard.
Actually, this lays out a pretty troubling roadmap when you think about it. The fact that
Absolutely.
Some healthcare professionals are foregoing this because of the administrative burden that exists, the potential lost paperwork within the healthcare system in general, and then the fact that the payment takes so long to get. But to your also point that preventative measures don't get completed at that time. You just get the worst case, which is going to the emergency room, which is, in many parts of the country, we have hallway healthcare because our healthcare system is overwhelmed.
Absolutely.
You mentioned that a bit in your testimony. How would maybe you could expand on ideas you have or your organization has that could potentially relieve some of this pressure, or at least the administrative burden, or even to speed up the whole regulatory process that exists?
Yeah, I think, when it comes to, we have to find a better way around the paperwork system and the amount of all of these, like the pre-approvals, and then them having to take paperwork with them to prove that they were at the appointment. So there's not only all of the leading up to the appointment, it's then once you get to the appointment and the paperwork beyond that. And then sometimes you have people who also, because of travel times and all of that, they miss getting the specialist to sign the paper, and then that impacts their next travel. So all of those pieces, so they don't realize that it's right from the start of the system up and down. And so then it impedes then their ability in future access to the program. I think what we need to do as healthcare providers is to really work together to establish a system on how we can more collaboratively tackle the length of wait time that it takes in the administrative bureaucracy to do this. We have had a few providers here in Ontario who actually took upon themselves to administer the NHB program, but the sad reality is they experienced the length of time and delay for getting the process payment back from NHB as well. And then what happens is it impedes the ability of the community to continue to do travel because they don't have enough cash flow to be able to do that. So again, I think that when we're looking at the long run and the long term, if we're, again, comparing upstream to downstream, it's so much less costly to catch them in preventative type stages when we're actually getting into acute care. We're already talking like there's something to diagnose and something to treat. So we've now missed this whole part of the system here where we could have prevented worst case outcome or outcomes that require more types of treatment.
Thank you, Mr. Schmale. We'll now go to Mr. Batiste. Mr. Batiste, you have 6 minutes.
So I'd like to thank the witnesses for their testimony, and I'd like to thank them for, we're hearing you loud and clear about the need not only to ensure that the prices and the costs are done more efficiently, but also that we need to catch up in terms of what our government is providing. I'm wondering if when we're looking at some of the issues that are in the northern areas or rural Indigenous communities, one of the things that I've often that is coming into my head when I'm thinking about these problems is that often the challenge is that we have to travel as Indigenous people to find the services elsewhere. I'm wondering if there, the underlying issue of capacity on reserves or in North, what can we do as a government to try to ensure that communities do have the capacity so that their community members don't have to travel off reserve or from the North? Is there a way in which we can work with universities? Is there a way that we can create programs that increases the amount of Indigenous participation in the health? And can you talk to us a little about if there's any best practices out there in Canada right now that are working to increase the number of participants we have from the Indigenous communities in the health studies? And I guess we could start with Ms. Lidstone-Jones.
Yeah, absolutely. I can give you some concrete examples of our network here in Ontario with the Indigenous Primary Healthcare Council. Many of our healthcare council, we actually are status blind when it comes to providing service to Indigenous peoples. So that's First Nations, Métis, and Inuit. We've entered into a lot of relationship agreements actually with our First Nations communities to bring care into those communities. Where we are challenged, of course, is our ability to have enough service capacity to do that. And right now, we're also trying to increase our capacity in a number of positions and primary healthcare providers that we get so that we can further our scope and our outreach. And we also are into relationships with, in our case, in Ontario, the Northern Ontario School of Medicine, to talk about how we train our students and how we also connect the Western and traditional approaches to medicine and how do we promote that more internally into our communities. The other thing that I think is also advantageous to our system, where we can bring things like doing pre-surgical clinics into the communities and gathering people who can do that. And when you can do things like screening buses and things like that, where you can have captured people actually go for care. The other thing that we've done is instituted mobile units. We were fortunate enough to get funds during times of COVID to use them as mobile units for testing, assessment, and COVID. We now have an opportunity in the system to have that for primary care service delivery that could take those services out into the community to do more of those prevention type things. Those are the things that I think we need to invest in to be able to take more services to the communities. So instead of communities having to go to where those services are, we need to look in the opposite to ensure that accessibility is there.
Okay, Ms. Jones, you talked about something that caught my attention about the land-based healing, and that as an example of a promising practice within Indigenous communities. Can you tell us a little bit more about that and how it's working effectively to address mental health with Indigenous youth, or especially?
Yeah. Huge Huge. We've seen a massive increase in the use of our traditional healing and medicines program, especially during times of COVID, where we had more increases in mental health concerns, people that never experienced anxiety before, depression, all of those things due to isolation. We actually, throughout our network, have created land-based programs where we have various components of it. We have hunt camps, fish camps, we have traditional teachings, we have ceremony where they can go in for specialized ceremonies, naming ceremonies. We've also had traditional healers that went out with our communities to learn how to pick traditional medicines, how to do and cure the medicines and use them for whatever purpose actually picking. The other thing is we found that the role modeling and mentoring of having youth out on the land with people who are able to navigate the land is also a huge piece, and that has been very successful for us. The other piece that we're working on in traditional healing, again speaking in the Ontario concept, is also doing better at, we refer to it as two-eyed seeing, but incorporating those primary care delivery with our traditional medicines and how to better connect those two services so that becomes harmonized instead of two disjointed programs. So those are things that we're working on right now, and we're doing a lot of work in that area right now because we've seen the massive increase of utilization as a way forward for people to, especially when it comes to mental health and addictions.
How much time do I have? Vice Chair? I think
You have 20 seconds.
Yeah, that's what I figured. Okay, so that's about it for me then.
Thank you very much. Alors, on va aller à Madame Gill.
Now, Ms. Gill, you have the floor. You have 6 minutes. Thank you, Mr. Chair. I would like to thank the witnesses for being here today. I have questions regarding a topic that we did not touch on. It was a very important topic during our study on housing, where we saw that housing was not accessible, was not available in faraway communities, which resulted in an exodus towards urban centers. So I'm wondering if this is also the fact that they don't have access to healthcare is a reason that would push people to leave their communities and their reserves. Would you like to answer first, Ms. Putlik? Thank you, Ms. Gill.
I will respond to you in Inuktitut.
Due to lack of housing, for sure. That's one big important reason. But most of the patients and escorts do go back home. A lot of people from the north will leave the north seeking employment in the southern cities, or due to various personal reasons, they do leave the north, escaping either violence and abuse. And then sometimes many of them are affected by substance abuse once they are in the south. But the majority of our
Donc, en fait, ce serait pas pour des raisons.
So this isn't one of the factors, one of the reasons why people leave their reserves. The lack of access to healthcare is not a reason. Someone who needs dialysis 3 times a week, for example, they won't leave the community?
Donc, je vais demander peut-être aux autres témoins.
I'm going to maybe ask the other witnesses to answer my question, even if their answer is also no.
Oui, j'aurais aimé entendre les autres.
Yes, I would have liked the other witnesses to answer my question.
Jones, do you want to take a crack at answering that question, and then we'll go to Dr. Tompkins.
Sure. I'm sorry, I just found the translation, so hopefully I caught it all. So if I understand correctly, you were looking for, do people leave the communities because of their treatment? The answer is yes. Some people do have to leave their community when it comes to treatment, especially, and you mentioned the use of dialysis. Dialysis is huge. It's not only the accessibility to the program, but access to the quality of water that is in a lot of our communities. So some of them are having to leave those circumstances to be able to access that program and that service. Anything that requires more specialized care, you have some people, and in fact, making the choice where they just choose that they're not going to do it and their healthcare gets worse because they have to leave so far. And the other thing, when they do leave, it's many times leaving by themselves to have to do that care. So there's the fear and the loneliness factor.
I'm sorry, Ms. Linstone Jones. I'm not sure if you understood my question. I don't mean leaving on a punctual basis, but rather to leave permanently to be able to have access to proper health care that is not available in their communities. So I don't know if that's what you understood, Ms. Linstone. So your answer is still yes?
That do that too, as well. And again, it depends a lot of time to the complexity. I can speak to that personally. I have a husband who has to be here in the GTA because of the complexity of the healthcare services we need. I'm originally from Northern Ontario, and we're here because of healthcare. So yes, the answer is yes.
And Dr. Tompkins, if you wanted to answer the question, I know you're in a different sort of part of this discussion, but go ahead if you wish.
I'll keep it short. So I would say that in terms of dentistry, since most of the treatment we do is very much on time, it would not be a cause for somebody. It would be very unusual unless somebody had craniofacial disorders in children that needed a lot of surgical care. But again, that would be viewed as a temporary, maybe 6 months or to a year leave, but not a permanent move away from the community.
Merci beaucoup pour vos...
Thank you very much for your answers. And I have another question, and maybe we can carry it over to the next round to give everybody a chance to reply. With regards to accessibility, and I know that distance is a problem and availability as well, because there are not very many specialists in most of the communities. And what would you recommend as a solution to solve these problems of availability and accessibility with regard to specialists? I don't know if you can envisage any possible solutions or suggestions. Perhaps Ms. Tompkins would like to start. Thank you.
To say if you build it, they will come. And thinking of dental specialists, and especially things like oral and maxillofacial surgical specialties who require highly technical operating suites, that if we were to see surgical centers in communities that have a high utilization of NIHB services, then you would have the oral and maxillofacial surgical specialists as well as the dental anesthesia specialists. So yes, that would be one of our recommendations. And may I ask Dr. Poon to comment on anything more technical on that?
Thanks for that, Dr. Tompkins. I think that echoes my exact feelings on that. An example would be pediatric dentistry wait times. Presently, there is probably in Central Ontario, we've heard stories of 8 to 14-month wait times for pediatric general anesthesia for dental surgeries. I think certainly setting up either remote surgical centers would provide pediatric dentists an opportunity to go to the communities to perform the work. So I would echo those comments.
Thank you. Thank you. We'll now go to Ms. Eadlout. Ms. Eadlout, you have 6 minutes.
Thank you, Mr. Chairperson. Before I will have a question to Maggie, but I want to respond to Marilyn's question. I know of 2 Inuit. One is from Sanikiluaq originally, and one from Pangnakto originally. They had to leave their homes and communities because they could not be served by the medical services in their community. They had to move to Ottawa for medical care because of dialysis needs. We do not have them in our communities. Now, I will ask Maggie. I enjoyed your presentation when you talked about how you have been involved for many years in health issues. And I was very pleased when you said you work with Largas and you talked about their medical escorts and how that could be improved. But we know people who stay at Larga, they have escorts and staff looking after them. And they have escorts. How do you feel about the escorts being on the payroll as a full-time job? Yes, the escorts who are interpreters, assistants, and who aid the patient, they leave their full-time jobs often without pay to take time off to do this service. And it is very important that they should be called a patient navigator under a payroll because they are essential service to the person that they're assisting. It is a very critical job they do, and they should be remunerated as such for the job that they're doing, which is very important. Lastly, I want to ask, we all understand that we Aboriginal people, Indigenous people, we have very traditional, good healers. There is a mental health services that you provide to First Nations and Inuit, and they use a counseling benefit under NIHB. What is the tracking system when it comes to mental health patients and outcomes? They also have to have escorts as well when they travel. I believe that they should be paid as well. Yes, we ordinary people, we have support systems. We have people and counselors that we rely on for mental and spiritual health. And we all need that to be whole and healthy. Traditional Inuit should be involved in traditional healing and medicines. It should be recognized as a very important service because we practice it today, and many are in need of mental health supports. And many will suffer from terminal illnesses like cancer. They need someone to support them as well, and someone to be there as a caregiver. We acknowledge them, but we should also acknowledge them with pay. So, can you give us, when you talk about the situation in Cambridge Bay that you briefly talked about, can you put that in writing and explain to us? Yes, I will write the report to you and explain the situation and what happened. So it's a very good case study of how we can be more community-based when it comes to healing and assisting our people. Thank you. Solio. I wish to ask you, Carolyn Litstone. Indigenous leaders who are involved working with youth, they are providing a very important role as role models and mentors. They ought to be paid as well. What do you think?
We pay them on payroll, and we view them as part and in alignment with primary care. We hold them as value of your doctors and your nurses and your NPs. That's where we hold ours. Similar to, I'm sorry, I'm missing the name of the previous speaker. We also fund our navigators. We call them natural helpers. So anytime somebody goes out into a medical situation or as an escort, we will help give an actual honorarium to that individual per day because they're there in a helper role. And we also recognize the importance, as you mentioned, the spirit is important. If we don't take care of that spirit, that is the way that we do that as a community, and that is part of our foundational teachings. And a lot of us as Inuit people share that, so we recognize that. So absolutely, we're willing to share any policies and procedures we have about that with anybody who's interested.
Thank you very much. We're going to proceed to a quick second round, a shortened one, starting with Mr. Vidal. Mr. Vidal, I can give you 3 minutes.
Thank you, Mr. Chair. Dr. Tompkins, I was watching your expression as my colleague, Mr. Schmale, was talking to Ms. Lidstone-Jones about some of the frustrations around the bureaucracy and providers not engaging, whatever. And I want to give you a quick chance, as you just heard the chairman is going to limit my time, which is fair. But I want to give you a quick chance to respond to your experience in your profession, if that's true there, and maybe with a quick addition as to what you think maybe some of the solutions might be to that challenge.
Thank you very much. I'll be brief because I will defer to Dr. Poon as well, who's our technical advisor. Definitely, as a provider, it can be extremely frustrating because you have a patient in the chair, they need the treatment, but you have to get pre-authorization or predetermination. And you know from previous experience that it's going to be approved, but unless you get it approved, they're not going to cover it. And so you have a patient who's in pain, and sometimes you have to send them away with a prescription for an opioid or an antibiotic, which contributes to a bunch of other problems, and then have them come back to actually have the problem addressed. And in between those appointments, they might end up in the emergency department at a hospital where all they do is give them more opioids and antibiotics. So if I may, I'll ask Dr. Poon to comment on that as well. But it is one of our recommendations is to reduce the administrative burden and the amount of pre-authorization for things that always come back approved anyways.
Thanks again. I'll just try and make it brief. Maybe I'll just give an example of what might happen in my office. I've been practicing dentistry for 42 years, most of the time in downtown Winnipeg, which is a high proportion of Indigenous patients, some of them from up north because of geography in Manitoba. For example, I'll give you an example of what happens probably at least once a week, maybe once a month. We have a patient from Garden Hill, Manitoba, which is a fly-in reserve with winter ice roads. He's lost his front teeth to an accident. They were extracted on the reserve by the visiting dentist. He has to wait for the ice roads to come in. He drives into Winnipeg, comes to my office. The NIHB program is supposed to be a comprehensive program that includes all treatments. He comes in requesting a partial denture. I can't proceed with that partial denture. I have to do a predetermination or a pre-approval with the predetermination center. And sometimes it's by fax. The approval process may take 3 to 10 days. This is the catch. It's so strange. It never is denied. Rarely is it denied. The patient reads the requirements for a partial denture. We know the rules. We submit it. It's not denied, but we still have to wait. After 3 or 4 days of being in town, he has to go back because he's only in town for a medical appointment or as an escort. So we couldn't proceed with that treatment. I don't have to explain to the people here how the cost of medical transportation, either to the system or to the patient. So that's my one in-person example where this is a problem.
Thank you very much. We'll go to Mr. Badaway. Mr. Badaway, 3 minutes.
Thank you, Mr. Chair. I guess my interest, Mr. Chairman, is with Ms. Lidstone Jones with respect to some of the comments she had made about community health centers and some of the initiatives that you're already on. So I guess a broad question, Ms. Lidstone Jones, with respect to what is your vision as it relates to Indigenous communities and establishing community health centers, including the services that we're discussing today, but other ancillary services as well that are accessible. When I say ancillary services, I'm talking about endocrinology, cardiac, neuro, things that sometimes we don't see in Indigenous communities that people have to travel for, but can be established within Indigenous communities. Can you comment on that?
Yeah, I'm thrilled if you're thinking in that direction, for sure. We absolutely promote a model of holistic health and well-being. That is our model of care. So we have a lot of integrated services already. So wherever we can integrate, we do. And that includes also, I know one of the previous speakers had asked a question about housing and things like that, where we can do supportive relationships that way. Those are the things like, for example, that became loud and clear during COVID, that one of the places that was housing became where you secure people to do housing. That became then an impact on healthcare, right, and healthcare delivery. So absolutely, we are fully integrated right now. We have nurses, physicians, we have midwifery under us, we have mental health and addictions, we have traditional healing and wellness, we have some rapid access medicine programs, we have programs where we can link up with hospitals where we can actually do testing on site. So those specialists will come to us and we'll bring the patients in that setting, a setting that they're comfortable and used to. We have oral, in some cases, some oral health dental programs, not as much as we would like, but wherever there is opportunity for us to expand those services, we 100% feel that that's the way to go, because then it creates a hub where people are not having to navigate individually pieces of the system. The system then is supportive of them rather than them trying to navigate the system. And that to us is about the primary responsibility of us as healthcare providers. So wherever we can do that, we 100% do that. And we have many, many models in place where we continue to integrate. So some of the things that we're starting to integrate now is, for example, home community and keep people in their homes and being able to do that in a way. We've also started to add in programs where we're doing palliation in the home. So we can help families navigate and deal with pain and all of those kinds of things. So wherever we can keep people in communities or as close to community as possible, we help facilitate.
Wonderful. And Mr. Chairman, I know you're going to cut me off any time now. But
yes, I am afraid I have to do that.
If I can just ask this in closing, Ms. Lidstone and Ms. Lidstone Jones, if you can contact my office so I can talk more about this, I would truly appreciate it, because it is in fact 100%. Something I'm looking at doing. Thank you.
Absolutely.
Thank you, Mr. Chairman.
Thank you. Madame Gill, je peux vous offrir 90 secondes.
Ms. Gill, you can have 90 seconds. I would like to hear Ms. Pulik and Ms. Lidstone Jones about a perfect model for availability of these kinds of services. What would they suggest? Thank you very much. Ms.
We'll go to Ms. Petulik. So, Ms. Petulik, did you hear that? Perhaps you could start.
It would be best to invest in infrastructure, to repatriate certain specialties, for instance, nephrology. People on dialysis have to be relocated to the south on a permanent basis until they are eligible for a kidney donor. And it's very sad to see, especially elders that are unilingual, having to leave their natural environment, their home community, not being able to speak a second language and permanently being away, and then having an escort here once in a while and not having permanent family members with them at all times. So it would be essential, it is essential and vitally important to invest in infrastructure with proper water filtration systems for dialysis treatment centers. Thank you. Merci.
Thank you. Ms. Idlout, question.
Thank you. My question to Maggie. I don't think the other members of parliament fully understand the vision care is not really available in Nunavut. Can you explain the importance and what we're lacking in vision care? The special eye care, they come to the communities maybe once a year or twice a year, and they have a very limited time in the community. Those who want to see the eye specialist do not all get seen, and young children especially who have eye problems are attending school with poor vision. That affects their learning. The eye specialists do not come to the communities often enough, regularly enough. And there are many patients to be seen in each community regarding eye problems. We need an eye clinic in the communities. Thank you. I hope that is a good response that you wanted or were looking for.
Thank you really sincerely to all of our witnesses today, Dr. Lynn Tompkins on the issue of dental care, and her colleague, Dr. Philip Poon. Thank you very much, Carolyn Lidstone-Jones, and thank you, Maggie Putulik, for shedding light on some of the challenges with respect to non-insured health benefits. Thank you for your testimony. Thank you for answering our questions today. You've made an important contribution to our study. Thank you. With that, colleagues, we'll suspend very briefly and prepare for the next panel. Thank you.
Miigwech.
second panel. We're here to, nous sommes ici pour...
We are here welcoming Grand Chief Ken Kikavichik of the Gwich'in Tribal Council, Isabel Wallace, a community health nurse with the Madawaska Maliseet First Nation, and Betty Villebrun, Vice President of the Northwest Territories Métis Nation.
Our panel today, just a reminder that on the bottom of your screen in the center, there's a little symbol that looks like a globe. That's your interpretation button. If you use that, you can get translation into the language you want to listen to. So don't hesitate to use that, because sometimes people will speak in French, English, or Inuktitut. So with that, the way we start is with each of the witnesses is asked to make an opening statement of 5 minutes, and I'll try to hold you to that. And so with that, I'm not sure which one is not with us, but I do see Isabelle Wallace in front of me on the screen. So je vais lui demander de commencer.
I will ask her to take the floor and to start with her presentation. Ms. Wallace, you have 5 minutes.
Oui, bonjour.
Thank you very much. Hello. My name is Isabelle Wallace. I'm a community health nurse from the Madawaska Maliseet First Nation, where I was born, and I'm a member of this nation. I'm proud to be a Wolastoqey nurse and have had the possibility of working in a number of First Nations communities, and including our unceded territories in New Brunswick. I have Indian status, have since my birth, and I think that my thesis on Indigenous cultural heritage and my professional experience mean that I can give my opinion on the uninsured benefits health program. I am honored to be able to be here to share my opinions with you. In order to situate my testimony, I would like to talk to you a bit about my community. The Madawaska Maliseet First Nation is in the northwest of New Brunswick, along the Quebec and Maine borders. We have 196 members who live on our territory, and we have 404 others that are outside the reserve. We are the only First Nations reserve which speaks mostly English, mostly French, and where English is a minority language, but because of violent assimilation measures imposed by successive governments, no one in our community speaks our ancestral language, Wolastoqey. In 2021, we had a significant victory on our territorial claims, following which we were recognized as having a great part of the city of Edmundston, which is on our reserve lands. You can see that we are therefore close to Edmundston, and our members have access to the regional hospital and health professionals in the private sector. As a community health nurse, my role has been to work in various sectors of health, including public health, community health, home care, and primary care. Before the pandemic, we already asked the nurse to deal with a complex and poor system. And we are already trying to manage these crises, plan for vaccination and tracing clinics, educating our communities, and finding innovative solutions for our health problems. The additional complexities that require the use of the NIHB program are an additional unnecessary burden for a community health nurse. I can tell you that there are many problems with the program that lead to racism in our region. As an example, last week I contacted a private healthcare provider in order to improve communication between that professional and one of my clients. As we were discussing about one of the members of my family, without this person knowing that I was a relation of this person and that I am myself a member of the Indigenous community, this person said, "Me, Indians, I don't deal with them." And after asking an explanation, in order to know if he was refusing service to First Nations peoples, we were told that all his clients had to pay in advance. And in his experience was that he had difficulty getting paid by an Indian. I think that my role as a nurse is to defend my clients and my family in order to have them obtain fair health care. And I also have to deal with racist remarks every day. Since without training in the program, my role is to educate providers to navigate the program. And unfortunately, I have many other examples of where I've seen concrete consequences of these types of closed attitudes, both as a client and as a colleague. I can talk about the difficult administrative burdens for the program or hours spent on appeals. However, I think that that would be a waste of my testimony time. In my opinion, the lack of information and training that continues to be shown by professionals, health professionals in all sectors, has extremely negative consequences for the health of First Nations, Métis, and Inuit. Instead of looking after their well-being, the program contributes to increasing the gap between these clients and Indigenous peoples. Thank you. I will happy to have been able to speak to you, and I will answer your questions. Thank you very much, Ms. Wallace. I think that Grand Chief Kanjuta is with us now. À vous, Grand Chef, pour vos témoignages.
Jen Greensey, good afternoon, Mr. Chair and honorable committee members. My name is Ken Kikovichik, and I am the Grand Chief of the Gwich'in Tribal Council of the Northwest Territories. I was elected in September of 2020, and I am here speaking on behalf of the over 3,500 participants to our Gwich'in Comprehensive Land Claim Agreement that we signed with Canada in April of 1992. I'd like to thank you for the opportunity to speak to the committee on today's topic. Today I will focus on how we, as the Gwich'in Tribal Council of the Northwest Territories, feel the Non-Insured Health Benefits Program, or NIHB for short, is failing not only our Gwich'in participants, but the broader majority Indigenous population of the Northwest Territories. The confusion and miscommunication between the NWT healthcare system and NIHB leads to gaps in non-client-centered care. The issue of medical escorts is a major concern for residents of the North. Our people are often at least a full day's travel away from larger medical facilities and centres in Yellowknife and Edmonton. For specialist care, community health centres in our communities of Aklavik, Fort McPherson, and Sigechik, along with our regional hospital in Inuvik NWT, are not well equipped. As a result, our residents are required to travel to these southern locations for the care that they require. It is common for us to hear of residents who require a medical travel escort and do not receive one. This is especially concerning when we are dealing with the elderly. Some examples that we flagged for NWT Minister Julie Green in the summer of 2021 included procedures with sedation, back surgery, those in a wheelchair or walker, and those who have language and mobility issues. When medical travel escorts are sought from the NWT Health and Social Services Authority, our people are often caught in the bureaucracy and required to prove their conditions. Otherwise, the denial for this essential support is seemingly automatically denied. As one can imagine, this leaves our residents and families very angry, frustrated, disappointed, stressed, and ultimately hurt as they are engulfed in the policies, procedures, and red tape associated with these government benefits in the NWT. Esteemed members of this committee, picture yourself being in what are supposed to be your golden years. Perhaps you are a residential school survivor. You are told that you require a medical procedure in the south far away from home. You are then told that you will be picked up by a van for transport to the nearest airport. You get to the airport often hours in advance because there are other trips to coordinate. You fly almost 6 hours into Edmonton through Yellowknife and then wait for the transport to your accommodations. By the time you lay your head on your pillow, as much as 16 hours may have lapsed. You wake in the morning and you're told where to be for pickup for your appointment. In all of this, it is expected that you are able to speak English, but there are many in the NWT who do not speak English as a first language. You arrive at the hospital and you wait, once again, for your appointment. Sometimes you may see people arrive after you and be seen before you. You wonder why, but you really don't know who to ask. When you finally see a physician or specialist, you may be asked some uncomfortable questions about your personal life. Things such as, do you drink or do you smoke? You may have limited means while in the city. Many are at the complete mercy of the system, as some cannot afford things such as a good place to eat, taxis, or a hotel should they get lost in the shuffle. At times, you may feel judged about your lifestyle, which is not common in southern Canada. Some of these individuals are over 80 years in age. You see, honourable committee members, we re-victimize some of our residents when there's no advocacy or support. Many NWT residents go without a medical travel escort, even when they require support. It is often those most vulnerable that are left without support and advocacy. That is the reason I am here speaking with you today, to highlight the serious issues that we find ourselves in the Northwest Territories. The interpretation of escort and exceptions policies appears to be a flashpoint for both the government of the NWT and NIHB. We often hear from the GNWT that the medical travel system is not a compassionate system. That is very odd terminology to be using in a post-truth and reconciliation world. Ultimately, honourable committee members, that is what we are seeking. Basic care and compassion by the government of the NWT and NIHB to respond appropriately to the diverse and unique medical situations of our people. We must establish a common standard for all residents of the NWT, Yukon, and Nunavut. I would like to share that 1, the provision of the NIHB benefits is not working for residents of the NWT, which includes our Gwich'in participants. 2, we are also seeing and experiencing systemic denials of medical travel escorts for our people, especially those who are Indigenous. 3, the medical travel system in the Northwest Territories appears to lack the compassion that is required for these very sensitive situations that our residents face. And 4, to this end, the Gwich'in Tribal Council would be pleased to share our experiences to the governments of Canada and the Northwest Territories so that we can develop a more comprehensive and coordinated NIHB system for all. In closing, the Gwich'in Tribal Council would like to recommend that, first off, a review be undertaken that looks into how the government of the NWT works with NIHB on the provision of medical transportation services. It is our understanding the NWT Health and Social Services Authority administers the NIHB medical transportation on behalf of NIHB to offer more seamless provision of services for patients from the Northwest Territories accessing care outside of their communities. We need to assess the timeliness of the program from approval denial and an expedited appeal process to provide some clarity. Second, if there are any opportunities to review the NIHB medical transportation provisions more closely, the Gwich'in Tribal Council will be open to exploring options on behalf of the government for medical transportation that includes or involves our Gwich'in participants. We recently applied and were denied for an NIHB navigator position. The reasons for this denial cited a population-based formula that dictated the creation of NIHB positions across the country. It is apparently one NIHB navigator for every 65,000 residents. Based on the complexity of the many issues and examples that I stated today, clearly the reality for northern residents is fundamentally different than those in the south. A standard nationwide formulaic approach once again does not meet the needs of the residents of the north. Hi, thank you for your time and opportunity to present today.
Thank you, Grand Chief. We'll now go to our third witness, Betty Vilbrun. Ms. Vilbrun, you have 5 minutes. So, Ms. Vilbrun, you're on mute at the moment, just in case. There you go. I'm still not hearing you yet. Can anybody else hear?
Monsieur le Président, sa microphone.
Mr. Chair, her microphone is not selected.
Here to be connected. Can you just check that part? So, Ms. Vilbrun, where your microphone or headset is connected into the computer, can you disconnect and reconnect it just to try that?
And Mr. Chair, if you could ask her to select her mic, that might also help with the problem.
Yes, and also, Ms. Vilbrun, down on the left-hand corner of your screen, there's a little microphone symbol. Beside that, there is an upward pointing arrow. If you would press on that, it gives you a choice of microphone. If you would select the microphone that's in your headset. So just in order to move on, somebody,
Mr. Chair,
Clerk,
if I
from IT?
Yes, we'll have IT contact Ms. Vilbrun, and in the meantime, you can start the questions.
Very good. So we'll do that, and hopefully we'll get back to you, Ms. Vilbrun, and we'll be able to hear your testimony. But we'll start with the questions for the first round. Mr. Vidal, you have the microphone for 6 minutes.
Thank you, Mr. Chair. And I want to thank our witnesses today for taking time to be with us. Grand Chief, it's good to see you again. We had a good conversation a few months back, and I'm going to start with you. And you answered a bunch of this in your testimony already, but I want to give you a little bit of a more opportunity to talk about the medical transportation issue. It's an issue that has come up in many of our meetings in the last few months or a few weeks talking about this topic, and it's obviously very different for you where you come from compared to my riding in northern Saskatchewan, which I know you're familiar with because you did some work in Saskatchewan some years back. But you explained many of the challenges, and I'm just wondering if you would take a minute and just offer what you think some of the solutions would be to those travel challenges. I know you talked about initiating a review, but what specific things that would work for your communities that would be a significant improvement in that kind of travel component of the medical transportation system of the NIHB?
Mr. Chair, would it be all right if I answer that directly?
Please go ahead. Please go ahead.
Okay. Thank you for the question, MP Vidal. I must add that I think before we get into solutions, I must also share the two-tier system that we find ourselves with here in the NWT. If you are a government employee, chances are, by a factor of 4, that you are a non-Indigenous person. Your medical travel benefits allow for a hotel of your choosing, rental vehicle or taxis, flexibility in travel, and the Treasury rate of approximately $135 per day for meals and incidentals. Many of the employees of the governments of the NWT or Canada often use these medical travel excursions to extend and see family or go off to other destinations on personal travel. It is a true benefit. If you are a resident of the Northwest Territories who is not a government employee, chances are you are Indigenous, as we compose the majority of the population. Some of these individuals are status Indians under the Indian Act. NIHB benefits apparently mandate that you either stay at the Larga House in Edmonton or the Vital Able home in the community called Delo, which is adjacent to the city of Yellowknife. Your location depends on where your medical appointments or procedures may be located. If either of these facilities are at capacity, as they often are, you are required to stay at the Chateau Louis Hotel in Edmonton or the Great Slave Hotel in Yellowknife. And I must say you are mandated for those locations. You're often told that you are to travel with as minimal notice as 2 to 3 hours prior to a flight, and God forbid that you need to modify your return. You are provided a response from the administration at the NWT Health and Social Services Authority that this can only be done at your cost, which is often anywhere from $100 to $500. You are provided with transportation that at times could have individuals waiting in an airport for up to 90 minutes, and a grand total of $18 per day for meals and incidentals. You then have to submit a travel expense for these costs. I might add $18 a day, and it may take as much as 2 months for a check or an EMT to arrive for you to be reimbursed for those expenditures. I think that is the first thing that needs to be addressed, is that two-tier system that we have in the NWT. I spoke about care and compassion, and we would welcome the opportunity at the Gwich'in Tribal Council to administer a medical travel program on behalf of NIHB, because we feel nobody knows our people better than our own people, and the personal situations that many of them find themselves in. That is more understanding, that provides a latitude for our managers to be able to make some of these decisions, because often what we find are government, the NWT staff that are enforcing and taking a very narrow view of the policy, which results in denials, which then gets escalated, appeals are denied, and then gets escalated to elected officials such as the Minister of Health, or people like myself or other MLAs of the Northwest Territories. And then some of those decisions are finally rescinded and changed and overturned to allow for medical travel escorts, as I mentioned earlier. So having that level of care, whichever way brings that level of care that I speak about that is so desperately needed into the system, however we do that, we certainly would see a dramatic improvement in the delivery of these services.
Thank you. I have a short minute left. I want to ask one other quick question, and Ms. Wallace, my question is going to be for you. We were having a conversation actually with somebody this morning, and I'm going to try to get this out quick. The challenge of retention of nurses in northern and remote communities, which I'm sure you all experience. I just want to give you an opportunity to speak to that really quickly, as I think we see people moving towards more urban centers and the challenge that creates in some of the northern remote communities like you and I come from. So I'm going to give you some time just to quickly speak to that and the challenge and maybe some ideas of solutions.
Thank you for your question, and it's a great question to close our nursing week. Also, I have experience in working in northern remote communities. The last one I was in northern Ontario during the wildfires last summer, and one of the reasons, well, the many reasons why I had to leave is the working conditions. We ended up being 2 nurses working 24/7, being on calls and just rotating between the 2 of us for a week, and our rotations were for a month at a time. And while we were down south, we needed to self-isolate for 2 weeks at a time before going back because of the pandemic. And my community, they were facing a shortage too. We only have 1 nurse for our whole community, so she was on medical leave, and they approached me and they asked me to cover, being the only RN from my community. So I gladly accepted, but that's just one of the examples why we have such a shortage of nurses. We're kind of sent everywhere, and having the training in primary care were kind of a rare commodity as well. And my training with Indigenous Services Canada was a great asset for my community too. But just the working conditions are just they're terrible. They were terrible before the pandemic, but things just have gone worse. I see lots of nurses going through the onboarding program through Indigenous Services Canada. They would last like 2 months to 6 months, and then they would leave. And I heard 1 year in Northern Ontario that half of their onboarding staff left within the first year of their employment. So that's a lot of costs, and I feel like if we just would invest more funding in the working conditions and the work satisfaction for our nurses, we would avoid having some break of services. We see some communities being without nurses sometimes, and that is tragic for me, and I don't see how that is still happening in 2022.
Thank you very much. We'll now go to Mr. McLeod for 6 minutes.
Yeah, thank you, Mr. Chair. Mr. Chair, I was hoping that I'd be able to ask questions to Betty Villebran. I'm not sure we're going to reconnect with her.
So if you want to do half now, and hopefully we'll get to her, you can take that chance, or do all 6 minutes with the other 2 witnesses.
I'll start with the Grand Chief Ken Kayukovic. I can never pronounce his name right. Ken, thank you for presenting here today. I think you brought a lot of information, a lot of real life scenarios, and many things that I've also experienced and heard about. The one thing that, and we heard from the federal minister talk about areas that they want to focus in, but there's one area that concerns me, and I want you to let us know if this is an area that you've had to deal with. It's regarding escorts, but more specifically, it's for people that are medevaced out, usually people that are in critical condition, on a stretcher, so they're taken from the health center and sent south, and they don't have an escort, and they're there for an emergency purposes. And when things turn around, when they're better, or it's time for them to go home, because they never came with an escort, they can't have an escort to leave. So the hospital brings them to the door and says, okay, sir or madam, it's time for you to go. A lot of times they're not dressed properly. A lot of times they don't speak the English language well enough. But it's a couple of horror stories that I've encountered over the last while. Can you just talk about that as an area that maybe we need to start really focusing in and making sure that it's escorts are provided? The biggest issue for me as an MP on medical travel is the issue of escorts.
Go ahead, Grand Chief.
Must say, MP McLeod, and thank you for the question. I'd like to share with you, as I often do, a specific example. In October of 2020, we had a 75-year-old elder who truly lived a subsistence lifestyle in our territory and found himself very ill at his remote camp in the Mackenzie Delta region. His family requested a medevac via helicopter, as this was during the fall freeze and the only means of transportation. The local community health center in Fort McPherson was operated by is operated by the NWT Health and Social Services Authority, was the main point of contact for the family. The RCMP had also been engaged to assist. The family was advised that an extraction via helicopter may cost $20,000 to $30,000, for which they would be responsible. Recognizing the personal emergency and the apparent lack of affordable options, the family reached out to the Gwich'in Tribal Council for assistance. As we are a shareholder in a helicopter business in Inuvik called Gwich'in Helicopters, we dispatched a helicopter to extract the individual. He then received the initial assessment of his condition at the Inuvik Regional Hospital. He had a lung infection, inflamed liver, a heart condition, and x-rays that were taken which revealed 2 masses that required further assessment. 2 days later, he was medevaced to Yellowknife and then eventually on to Edmonton to receive further care. All told, the helicopter extraction cost us a grand total of $2,215. However, it took intervention by us as an Indigenous government to make this happen. The charge was eventually reimbursed by the NWT Health and Social Services Authority 2 months later. To add insult to injury, when seeking travel to meet the patient as an escort, his sister was denied medical travel from Inuvik to assist and advocate for her brother. As a result, the family was required to pay for a one-way ticket from Inuvik to Edmonton at a cost of approximately $700 plus accommodation. After the bureaucratic process of submitting multiple letters from an approved physician to the NWT Health and Social Services Authority, all of which were denied, a separate request was made directly to the NIHB program by a social worker the family was in contact with, which then approved the hotels and meals 5 days after the helicopter dispatch. Sadly, the patient in care passed away about a week later from cancer. NIHB required that the patient's sister return home on the following Saturday, 2 days after the elder's death. Arrangements with the funeral home to respect the patient's wishes for cremation were required. However, due to COVID-19, the funeral home was limited in its ability to respond quickly. The family wanted their loved one cremated with his remains transported back to Inuvik, followed by a 2-hour drive on the Dempster Highway to Fort McPherson. Once again, the GTC was required to intervene and cover costs of accommodation and allow time for the family's wishes to be respected. The repeated requests to the NWT Health and Social Services Authority were denied due to a lack of disclosure of a reason for the patient's condition in the many letters that were submitted. The physician was limited in what they could include in the letter due to health information disclosure requirements. Thus, the request was caught in the conundrum of a catch-22 situation. I see this as a prime example of reasons why, in medevac situations where you do have a patient that is suffering from a severe condition, should be automatically provided with a medical travel escort that would follow soon after, as many of these individuals are unable to actually travel in the medevac with the patient itself.
Thank you very much. I understand that Betty is with us now. So although I can't see her, I understand she's with us. But Ms. Vilbrun, you have 5 minutes to make your presentation. So, Ms. Vilbrun, we can't see you at the moment, but you are unmuted. Can you hear? Can you perhaps turn on your camera? There we go. And would you like to start talking, see if we can hear you? No, we're not hearing you, unfortunately. I guess I'm very sorry, but we'll have to see if we can at least get your written brief. But we'll have to carry on with the present or the panel today. So I will now turn to Madame Gill. Madame Gill, avec les deux témoins que nous avons.
You have two witnesses, so you can ask questions. Thank you, Mr. Chair. I would like to ask Ms. Wallace a question. I would like to congratulate her. She's the first Indigenous woman to be a nurse in her community. And she also worked in Northern Quebec and Northern Ontario during COVID. I would like to thank her for that. My mom is also a nurse, and I know what being a nurse consists of. She mentioned the working conditions of nurses, but health is a federal and a provincial issue. And I would like to have her input on the situation. Does she believe that the increase in federal funding for health transfers would be a good thing, and would it improve working conditions of nurses in these communities, and by extension, would it improve healthcare for Indigenous people, Métis and Inuit people? Thank you for your question, and thank you for thanking me. My community is very proud. They are proactive in our education. They helped me throughout my education during my undergrad and my graduate degree. So I'm so happy now to be back home in my community to give back. If we increase federal funding, this will improve our working conditions. That goes without saying. I'm the only nurse, and so I do a lot of things. I really do so much in a single day. I could be fielding about 40 phone calls, be on house calls. The doctor comes once a week, and in between those visits, I'm constantly solicited and consulted. I'm also raising awareness on social media. So I do so much work that I can't even list everything I do in a single day. Often I take a step back and I tell myself, if I had an auxiliary nurse or if I had support staff that could make house calls and be my eyes and ears, my hands, and then report back to me, that would help me so much, because sometimes I'm too late in identifying a health issue or a problem, and that's when it's morally difficult as a nurse. So with increased funding, it would improve the situation. My colleagues know that I cannot keep up this pace in the long term. With the pandemic, we realized that the workload is a lot heavier than it used to be, but right now, as the nurse who knows the system. I'm the only one who knows the ins and outs of this system in my community. I must try and find funding and advocate and ask my peers if I can have help, but I can't even find time in a single week to do that. So yes, we need more financing, more funding, more help for the nurse, and so working conditions and workplace satisfaction would improve.
And then I would have more time to give to my community, to the people I help. For example, there's someone who comes to help me at the clinic, and she comes. There's also a doctor who comes, and I can help, and we can all contribute to community health. And so I'd like to know whether more money in the health transfer would improve the situation. And I can imagine that you're a model, an example. Of course, you're the first nurse in your community, and would you like to try and encourage other people, like the young woman that you've mentioned? But I can understand that it's a heavy workload, and I can understand that you want to bring more people in to help you. And I think that this is also can have a negative effect on your own health, all this workload. Yes, absolutely, because I've already had an experience of burnout because of my experience in the north and the lack of nurses in the north and all the problems with X-rays and the lack of facilities in the north. I think I can't even imagine how I managed to survive in that kind of situation, but it was basically adrenaline. And I think that burnout is very common with me and my colleagues. And it's a good thing that you've noticed, that you've noted that. And your experience in many different communities and situations has been very valuable. And it must be difficult as well to be a nurse in an Indigenous community because there's a lack of specialists. But often a nurse has to be kind of a one-person show. And yes, absolutely. And in the week where we were working 24 hours a day, I was so exhausted that I didn't really even have time to eat or even have a normal routine to protect my own personal health and mental health. So you can imagine that we go to bed at night and we don't. But the phone is right beside the bed, and we never fail to answer, and we're constantly called upon. And normally you go to the community clinic from 9 to 5, and that's where we do vaccinations. And we deal with ordinary problems, but there are always emergencies that come up, and often we didn't have time to do all the vaccinations we needed to do, and I was always afraid that I might have missed something or something hadn't been done. But my colleague kept saying, no, you're doing your job, don't stress. And so I tried to work on incident management at the national office in Ottawa, and this is one of the reasons why I went to look into this problem and to try and better understand the system and how to improve it. And I also noted there were evaluations made by colleagues who were up all night, and I've done evaluations, things that could have been treated better, and there are things that could have fallen through the cracks as well. Thank you very much, Ms. Gill. But since you recognize that this is the week where we recognize the nurses, you mentioned your mother, and I would like to say as well that my mother was a nurse, and I'm married to a nurse. So bravo to the nurses of our country. And we'll now go to Ms. Midlaut.
First, I'd like to thank you for your wonderful presentation, very informative. It gives a better picture of what's going on in the field. And when you talk about those situations we know that it affects everyone in the communities, and we have all encountered similar problems. My question is, when it comes to mental health counselors and healers, how are you keeping track of Aboriginal, Indigenous healers? What is the current approach for tracking mental health outcomes of First Nations and Inuit who use the counseling benefit under the NIHB program? And how are those results being reported to the Indigenous communities and the government? If you could all respond to this, I would appreciate it. Thank you.
If you're ready to respond, Grand Chief, go ahead, please.
Thank you, Mr. Chair, and other members of the committee, and MP Adloat for your question. At the current time, there isn't a very formalized process for the tracking or listing of our healers and mental health counselors with our organization. We do have some what are known as resolution health support workers in each of our communities that is providing part-time support, especially when we're encountering tragedies or deaths in the community. They provide immediate support, but on an ongoing basis, they provide that localized community support. What we are finding is the most effective, however, is on-the-land programming. And to that end, the Gwich'in Tribal Council is investing significantly in partnership with the Government of Canada to retrofit a wellness facility about 15 kilometers just south of the town of Inuvik on the east branch of the Mackenzie River, so that we can offer mental health and wellness programming in our communities, not treatment centers per se, but maybe detoxification, maybe aftercare services we'll be able to offer in addition to other services locally that just allows our people to reconnect with the land, which we find is incredibly powerful to restoring their mental health. In terms of how it is reported, I don't have that data directly in front of me. However, I can say that we do have the workers and the staff with our health and wellness department that is able to provide that vital service at the community level.
Madame Wallace, est-ce que vous voulez répondre à la question aussi?
Ms. Wallace, would you like to answer as well? Yes.
Mental health services. We do have 3 social workers, and we sometimes would send people to neighbor communities like Tobic First Nation for like land-based healing. Unfortunately, we don't have that in our community. We have the detox center, but oftentimes people are reluctant in even going in our region for that type of services just by fear of stigma, and because we all know each other. If they see their car, if members see their car, even at the social worker's office, that's something that they avoid, and so there's a big gap in mental services in our region.
Thank you. It further states that would you have a resolution or a recommendation how we can improve the recognition and of mental health workers, traditional mental health workers who are community-based? Do you have any recommendations how we can bring that up to par with other counselors?
Do you want to start, Grand Chief?
Yes, sure, Mr. Chair. My recommendation would be to look at it in a manner that is well removed from Western science, if you want to call it that. And what we are finding is the traditional approach to mental health counseling has been providing a counselor from outside of the community into the community. And we're a firm believer that our counselors exist and they interact on a less formal basis on a day-to-day basis. And what we are finding is the most effective is providing people who will listen to our people and not judge them for their particular situations. So in terms of improving the recognition of mental health workers at the community level, it's removing all of the credentials, if you will, all of the very high levels of post-secondary education, and recognizing and placing value on the social awareness and the knowledge of our culture, our language, our protocols, and understanding how people are provided with that counseling, as we would say, in a Gwich'in way, which is a lot of listening and not much talking.
Thank you very much, Ms. Sidlout. We're running up against the clock, but we can have a quick second round like we did the first time. If committee members are willing, we could start with Mr. Schmale for 3 minutes.
Thank you, Chair, and thank you, witnesses, for this great testimony. Maybe I might continue with Ms. Wallace. We were talking about mental health just a little while ago, and in previous testimony in this meeting and in priors, we heard about the bureaucracy being a barrier to care, especially in the preventative side of it. Just the bureaucratic red tape, the issues with communication, reimbursement, et cetera, et cetera. I know you talked about it earlier on in their testimony and in questioning, but maybe we can expand on that in terms of the mental health side of it. Are you noticing and have you experienced situations where mental health, especially at the preventative side, really had extreme delays in getting access to treatment that then led to an even worse case where individuals, perhaps for a whole variety of reasons, were being taken to a hospital emergency room or worse?
Thank you for your question. Yes, in many instances where we would sadly have cases of overdoses, and we know it would have been preventable, but because we didn't have the connectivity or even the staff to run the programs to connect them virtually with a mental health professional, even if it's a psychiatrist, or even if we remove all credentials, if we want to provide land-based healing or traditional healing. So I've seen many overdoses that it's very frustrating because we know it would have been preventable, and as nurses we don't have the time to even sit down with our patients and have a conversation. It would often not happen when they're on their hospital bed and the action has already happened, and then we would try to debrief with them. It happened that over the weekend I had instances where I couldn't connect with a social worker or a professional, and I was told by a doctor that was sitting in his apartment in Toronto who said, well, we won't be dealing with mental health crisis on a Friday night. This has to wait until Monday morning. So that was unacceptable. I tried to advocate for the patient, but I had to send her back to her home. But she was high risk of committing suicide, and that's very heartbreaking. And we worked very hard over the weekend to make sure that she was safe. And as nurses, we were too. But that's what we were told, and often the doctor is the one who will decide who will be sent down south and if they can justify it. So that's one example, yes.
Thank you, Mr. Schmale. We'll go to Ms. Atwin for 3 minutes.
Thank you, Mr. Chair, and thanks so much to our witnesses today for joining us and for your testimony. With my short time, I'd love to ask questions to Ms. Wallace, et je vous remercie de vos présentations.
Thank you very much for your presentation. It's always a pleasure to hear you and to meet with you.
Instances of racism and the systemic racism that's part of the system. I'm wondering as well about whether there are significant language barriers to accessing, services through NIHB, and if you could speak to that.
Absolutely. Being the only, majoritairement francophone.
as one of the only Francophone nurses in a Francophone community. I mean, there are services available in other communities, and often we think we're in this corner of the province, and often I have to turn to Quebec to find resources and materials, and there's not that much available here in our community, and my colleagues and other health professionals try to contact people on the helpline, and often there's nobody who can speak French, and there's no one there to answer questions in French. And that leads to delays and frustration. I've heard people, professionals who can't register with the program because they're not able to communicate with somebody who speaks French. And I think that's unacceptable because the program is there, and there are people that want to work with the program, but the language barrier is something that's real, and this is something that must be reviewed, and often people on the helpline try to call Quebec, and the system is different, and that means that there's a lot of lost time.
And members of the 2S LGBTQ plus community as well?
Absolutely. My brother is a transgender two-spirit, and we ran out of options for them. And essentially, what I had to tell them is move to Montreal and seek private services because I don't have the answers for you. Our community doctor couldn't provide the care, and it just came to that point where they moved to Montreal, unfortunately.
Thank you very much. We'll go to Madame Gill. Madame Gill, vous avez à peu près 90 secondes.
Ms. Gill, you have about 90 seconds. Thank you very much. One last question for Ms. Wallace with regard to language. I know that in recent meetings with regard to Indigenous languages and for the Dene, for example, to get services in their own language, and you've been talking about language and your community seems to have this problem since it's a Francophone community, and what you need is so that people can get help in their language. Yes, exactly. This week I've been thinking about trying to find solutions. We talked about funding for getting a navigator for the system, but we don't have enough population. And this would be important for our community to have someone Francophone at least. We're working on the French language, but also our own native language. But we are people who continue to speak our native language, but it's threatened. But it would be very important to have a Francophone navigator to help us find services. We are not the only Francophone First Nation. There are others, and so it would be important to have a Francophone navigator to help us. Thank you very much.
Time for a quick question, about 90 seconds.
Thank you. Very quickly, I will ask if there was a commission. There was a Truth and Reconciliation Commission produced some recommendations from 18 to 24 recommendations. Have you kept and worked with the recommendations? Have you implemented those Truth and Reconciliation recommendations in your work?
Do you feel an adequate job implementing the calls to action?
So I'm sorry, Madam Midlaut, did you direct that at a particular witness?
I'm sorry, to both.
Okay, well, we'll have time for one. Is there a preferred witness?
Yes, the Grand Chief, please.
Go ahead, Grand Chief.
Thank you for that. I guess we live this every day, and it all speaks to how our people are being treated in the system. And full disclosure, we are minority owners of a company called Larga Limited that provides boarding home services for medical travel for visitors from the NWT in Nunavut in Edmonton, Alberta. We've been providing this for over 30 years, and the genesis of Larga House was that we were seeing residents returning to our community sicker than when they left, and oftentimes these individuals were being medevaced. It was determined that the major reason was the diet that was imposed upon our medical travelers. The early owners of Larga decided to propose to the government of the NWT that they purchase a home staffed with Northerners who relocated to the Edmonton area and arranged at times for the provision of traditional foods such as fish and caribou for the residents. From the recognition of this gap and the service that was created as a result, Larga Limited has been a tremendous success story, offering residents of the North a home away from home, while also having the ability to interact with others who are on medical travel themselves. Larga has now expanded into other jurisdictions, which I am sure you're aware of, such as Winnipeg and Eastern Canada, because it is culturally considerate care for those who need to be in Southern Canada for short periods of time. Truly a model that was well ahead of its time in a pre-TRC world.
Thank you very much. That brings us to the end of the panel. I would like to thank Isabel Wallace for her testimony. I would like to thank Grand Chief Kikavicic for his testimony today and for answering all of our questions. And I want to thank Betty Vilbrun for being with us. I'm sorry we could not hear your testimony. I'll be speaking to the committee to see if there's a way we can hear this. We have one small window left because we would like to have heard you and ask you a couple of questions. So we'll get back to you on that. But thank you very much to all of our witnesses today. And for the committee members, before we wrap up, there's three very quick things I wanted to do. One is to remind you that the draft of the House study, you should have received that today. And we'll be discussing that 1 week from today on the 20th. That's the second study that we did, the House study. The second thing is, and this is addressed to the Conservatives, there was an email from my colleague David asking whether you would be ready to hear our first batch of witnesses on the emergency preparedness, the next study after this one, to focus on those in the firefighting area, because at the moment, those who are focused on floods are pretty busy these days. So we would hear from them in the fall. Mr. Schmale, are you all right with that? Or if you're not there, Mr. Vidal?
I believe so. I don't recall seeing that email, but I will have another look for it.
Okay, the NDP and the Bloc and the Liberals are okay with it. We're going to have witnesses, but we will focus on firefighting. They'll be busy later on this year, unfortunately, probably, but at the moment, it might be the best group to hear from. And then finally, we do have another session on non-insured health benefits next Tuesday. At the moment, we had 1 hour reserved for 3 more witnesses, followed by an hour to discuss drafting instructions for the non-insured health benefits study. One possibility that might allow us to hear from Ms. Vilbrun is if we had 4 witnesses and went for an hour and 20 minutes, and then we reserve the last 40 minutes for drafting instructions. Is that something that would be acceptable to the committee members? I see some heads nodding.
They're nodding.
All good. We're good with it all, Mark.
Okay, so Betty, if you're still listening to us, we're going to get you back next Tuesday. Hopefully you will be available and we'll hear your testimony. With that, I wish everybody a happy weekend, and this meeting is adjourned. Thank you.